Yes. So nephrotic syndrome is characterized by massive proteinuria, where we have excretion of more than 40 milligrams of protein per meter square per hour of urine excretion. Or, as Devansh rightly said, it is more than 1 gram per meter square per day. Devansh, what is the dipstick value for proteinuria?
Sir, 3 plus or 4 plus?
Yes, that is also correct. Or is protein creatinine ratio more than 2? It is also characterized by hypoalbuminemia, which means that your serum albumin levels would be less than 3 grams per deciliter. Due to less albumin in blood, there would be decreased oncotic pressure. And as we have studied in pathology, that can lead to edema. Edema of the entire body is termed as anasarca. It is also characterized by hyperlipidemia. With that brief introduction about nephrotic syndrome, let us start with how do we exactly present our renal case. Okay, so Devansh, because you had attended yesterday's session, and if you have your notes with you right now, can you tell me a sample demography just like you are presenting a nephrotic case? Just make up something and read out the demography for me. Devansh, are you there? Or is Shaurya, if your microphone has started
Yes, yes.
working? Yes. So if you could go back to your demographics notes and just read out a sample demographic for me for this case of nephrotic syndrome.
So, do you want me to say in a statement like that my patient XYZ
Yeah, in a
five?
statement form.
Okay, okay.
Yeah, just like you are presenting your case.
So, my patient XYZ is of 3 years, hailing from B1D, uh, born to a non-consanguineous marriage and first by birth order, presented with the chief complaints of uh, frothy urine. Uh,
Okay, no, that's enough. That's enough.
okay,
See,
okay.
you presented well, but I think you missed the point about the informant being mother and
Yes,
whether
yes,
the informant is reliable or not.
yes, sir,
All
yes.
right. So we discussed about the relevance of name in yesterday's session, and I told you that I'll be discussing the relevance of age and gender individually in each of the cases. So, what is the relevance of age in a renal case? So, minimal change disease causing nephrotic syndrome is more common in age group of 1 to 8 years, whereas acute glomerulonephritis, which is another renal disorder, is more common in school going children. When I say school going children, I am referring to the age group of 5 to 15 years. Another disease which is commonly seen in this age group is rheumatic fever. Okay, so some more people have joined. Anyone who has attended yesterday's session, please raise your hand or just type in the chat box so that I can know whom I can ask questions related to yesterday's sessions. It is absolutely okay if you're not able to answer it, but please do let me know. Okay, next. What is the significance of gender in a renal case? So, in a child more than 1 year, urinary tract infection is more common in females compared to males. Next, now how do we present our chief complaints and history of presenting illness? You will say that the patient came with chief complaints of. What are the expected chief complaints in a case of nephrotic syndrome? He could either be having facial puffiness, he could be having leg swelling, abdominal distension, or decreased urine output. The first three essentially mean that the child is having some sort of edema. My suggestion is that you must keep your chief complaints either one, two, or max to max three, not more than that. Because each and every chief complaint will have to be described in detail in your HOPI, and you don't want to waste a lot of time in describing all this. Secondly, all of your history has to be in patient language. How do we represent this chief complaints? So you will mention your complaint and since what duration is it present. For example, facial puffiness is present since 5 months and decreased urine output is present since 14 days. The complaint which appeared first has to be mentioned first, even in chief complaint. All right. Next comes history of presenting illness. When you begin with this, your wordings will be patient was apparently all right 5 months ago when he noticed, or more so in pediatric case, it would be the mother who has noticed our first chief complaint, facial puffiness. Now, each of your chief complaint has to be described in terms of onset, duration, progress, aggravating, and relieving factors. There are some, Tanushri, please mute your mic. There are certain other points used to describe these complaints. Wherever they are relevant, I will be mentioning them in those cases. So, what will be the onset? It can either be sudden, it can be an acute complaint, or it can be insidious, which means that the onset was more of a gradual onset. Duration, as in this case, 5 months, and progression. So, your complaint could either be progressing in intensity, severity, or it could be static. You have to describe your progression as, for example, in this case, you will say that the facial puffiness was, that the swelling was initially on the face, and later this swelling progressed to involve the entire body. One more point that we mentioned in this is that what is the diurnal variation? Edema due to a renal cause would be more so better noticed in the morning and it decreases as the day progresses. So you will say it is more in the morning and decreases as the day progresses. One question that you can expect from your examiner at this point of time would be what are the differentials of edema? So, Sanskriti, can you please unmute and tell me what could be the possible causes of edema in this child?
can be cardiac causes. Then this is
Okay.
uh, yeah, nephrotic.
Yes. What else?
Uh, uh, yeah, ascites, but yeah, liver causes. Then
Yes.
um,
Okay, that's good. So cardiac failure can lead to edema. This type of edema would be more so in the dependent areas of the body, hence starting first in the legs. In a bedridden patient, you can expect edema to be present in the sacral region first. What about renal edema? Renal edema would be first seen on the face. Causes can be nephrotic or nephritic syndrome, and it is worse in the morning. As she mentioned, hepatic causes. So, in cases of cirrhosis, ascites would be seen first, and then there would be edema of other parts of body. Whereas in a case of nephrotic, edema of other parts of body would precede ascites. So the progression can also help you in ruling out the other causes for edema. Apart from this, we can have nutritional causes of edema, such as kwashiorkor, wherein due to hypoproteinemia, we will be having edema, or due to nutritional anemia, which leads to cardiac failure, again leading to edema. Next, we can have allergic causes of edema, and these would be associated with urticaria and pruritus. Endocrine causes include myxedema and Cushing syndrome. And lastly, localized edema can be caused by trauma and filariasis. As I mentioned, anasarca is the term used to describe generalized gross edema. All right, so far so good. Yes, nutritional. That's correct, Sanjana. Next, we come on to negative history. See, negative history is not a separate heading per se. It is a part of your HOPI. Uh, this will include a list of questions that you will be asking to your patient, and all those questions where he says that this like very agrees that this history was present, that will be placed at the top of your HOPI, which will be followed by the rest of the negative history. So yesterday we discussed. Um, Chris, are you there? Can you please unmute?
So,
Yeah. So what are the three parts of negative history?
um, the system, complication, and etiology.
Yeah, it is etiology, it is complication, and it is associated symptoms. That's correct. So, what all will you mention in associated symptoms? So, I mentioned four of the common presenting complaints seen in nephrotic syndrome. This patient had two of them. So, the other two will become part of your negative history. So, as a part of associated symptoms for nephrotic syndrome, I'll mention that there is no history of abdominal distension and that there is no history of negative leg swellings. So this is negative history of associated symptoms. Next comes the negative history of etiology. So a basic thing for not just pediatrics, but for other cases also. See, what we will do is we can't rule out each and every disease just based on history and examination. We will be ruling out 3 to 4 of the important ones, which can be asked on history. It is not necessary that you will be able to tell your confirmatory diagnosis just by asking negative history. So what all do we ask over here? First of all, I want to rule out cardiac cause as cardiac cause for this edema. So I will ask whether there is any history of breathlessness on exertion, or any history of chest pain, or history of recurrent respiratory tract infections. Now, why am I mentioning recurrent respiratory tract infections to rule out cardiac cause of edema? I'll explain this part when we cover CVS cases. Next, I want to rule out hepatic cause of edema. So I will ask whether there is any history of jaundice, vomiting of blood, also called as hematemesis, or whether there is any blood in stools. Some of you are in third year and you might not understand exactly why are we asking symptoms of hematemesis or blood in stools to rule out hepatic cause. You will learn this in your theory as and when it comes. Right now, just make a note of it because portal hypertension and cirrhosis is a whole topic in itself, which I won't be covering right now. Next, I want to rule out whether whether there is a nutritional cause for this edema. So I will ask if there is any history of failure to gain weight or reduced appetite, or whether there is any history of passing through greasy, bulky stools. If there is no such history, it helps me to rule out malnutrition. I am referring to kwashiorkor and malabsorption as a possible etiology. All right. So we ruled out cardiac cause, we ruled out hepatic cause, and we ruled out malnutrition. Now, assuming that it happens to be a renal cause for this edema, I want to now rule out whether it is nephritic or nephrotic. So I will ask whether there is any history of cola-colored urine or headache, blurring of vision, or any history of seizures. Headache, blurring of vision, and seizures indicate hypertension, which is a very common feature seen in nephritic syndrome. Okay, so this rules out nephritic syndrome. Next, I will assume that this is a case of nephrotic syndrome. Now, there are many causes for nephrotic syndrome itself. We have primary lesions such as minimal change disease or focal segmental glomerulosclerosis. Secondary causes such as malaria, amyloidosis, or SLE. You will read all this in your theory. I'm not going to write down everything. Or there can be congenital nephrotic syndrome associated with certain mutations. So I will be only asking about one of them, that is SLE. I will ask whether there is any history of fever, skin rash, or joint pain. SLE being a secondary cause of nephrotic syndrome. It is highly likely that None of these points will come positive. That is because most common cause is minimal change disease, which leads to idiopathic or primary nephrotic syndrome. Next comes negative history of complications. So, Kshitija, can you please unmute and tell me what are some of the complications that we can expect in a case of nephrotic? Loss of protein is a characteristic, that's correct. What will it lead to? What complication can occur due to loss of protein? Anyone else who knows the answer can type it in the chat box. Stroke, yes, that's correct. Sorry. So I will be asking history of pain in abdomen, whether he has any breathing difficulty or if he has had any history of fever. When I ask pain in abdomen, I want to elicit a condition called as spontaneous bacterial peritonitis, which is a complication in nephrotic syndrome. When I ask breathing difficulty, it could be either due to pleural effusion, pulmonary edema, or it could also result because of massive ascites. And I ask history of fever because patients of nephrotic are more susceptible to infections because of loss of immunoglobulins through urine. So that becomes your negative history for a case of nephrotic syndrome. Does anyone have any doubts so far? You can type it in the chat box. All right, if no doubts, we will move ahead. So, Krish, what comes after HOPI? Krish Vasa.
Past history.
Okay, so can you just frame up a sample past history for this case? You can refer your notes and just present as if you are presenting a case of nephrotic.
Mhm. The child presented to the hospital with similar complaints 6 months ago,
Okay. What else will you mention?
uh, for which he was given a tablet regularly for 6 weeks, followed by alternate day for 6 weeks, and
That's correct.
and
And what were
symptoms
the
were
other points that we discussed in yesterday's session? What were the other points that we discussed in yesterday's session? Like, which all points do you cover in past history? I want you to speak those.
so I actually came in midway in
Achha,
yesterday.
okay, okay. Okay,
Yeah.
no issues. So, what is the relevance of past history in this case? As he mentioned, there can be similar episodes in past, more so relevant in cases of nephrotic syndrome and urinary tract infections, which commonly recur. Also, I'll ask if there is any history of recent respiratory or skin infection, which will suggest me that it could possibly be post-streptococcal glomerulonephritis. Next comes antenatal history. So, if the mother has had oligohydramnios during her pregnancy, it could point maybe the baby has had some congenital renal disease. That's the relevance of antenatal history. Next comes birth history, followed by immunization history. Immunization history becomes relevant because these children have increased susceptibility to infections by encapsulated organisms. So maybe the patient had been advised certain additional vaccines in the past. So you will ask whether he has been advised any additional vaccines such as pneumococcal vaccine. Next, what can we expect in developmental history? See, all these points have been discussed in yesterday's session in detail. I'll be sharing the link for yesterday's session, and after this session, please go through them because I am only discussing the additional points for this case. Okay, maybe the child would have retarded growth in case it is a case of chronic kidney disease. Coming on to dietary history, the child may have certain restrictions in the diet, such as no added salt in diet, and he would be advised a high protein diet to compensate for the loss in urine. Next, how can family history be relevant in this case? Suppose there is history of certain renal disease in family, or there is early onset hypertension along with hearing impairment. Can you guys type in the chat box which condition, which syndrome am I referring to here? Early onset hypertension with hearing impairment seen, which runs in families. Yes, that's correct. Uh, Whoever that is, please edit your name and please write your entire name. It is Alport syndrome. So that is about the relevant points for history. Now we will move on to the examination part. So in general examination, what if the child has altered sensorium? In a renal case, I would suspect that the child is having uremia as seen in chronic kidney disease. What are the abnormalities I should seek for in vitals? So I will especially check for BP, which may be high if some underlying renal disease is present. Next, when we talk about pickle, do mention about edema in your case. In anthropometry, keep in mind that a child of nephrotic syndrome who has had multiple relapses will definitely have growth failure due to steroid intake. In head-to-toe examination, what all points should I expect? I might find Cushingoid faces, cataract, glaucoma, osteoporosis leading to pathological fractures, and striae on the skin due to steroid-induced Cushing's. So all this can be related to steroid intake. If you guys have read about nephrotic syndrome, at this point, you won't wonder why I'm mentioning steroids because the treatment for nephrotic syndrome is prednisolone. I hope you guys have read nephrotic before coming to the lecture. The patient can have uremic breaths if it is a case of chronic renal failure, or he may have hearing impairment, as in Alport syndrome, which we just discussed. What can be the abnormality that we expect in genitalia? So, scrotal or vulval edema is very common in nephrotic syndrome. All right, that is about general examination. What all points will you be seeking for when taking a case of nephrotic? Next, we go on to the systemic examination. Any systemic examination has four basic parts: inspection, palpation, percussion, and auscultation. We start with inspection of abdomen. What all points do we cover when we are commenting upon the abdominal inspection? First of all, umbilicus. Whether it is central, whether it is shifted downwards, or whether it is shifted upwards. You can expect the umbilicus to be shifted downwards in cases of gross ascites. Secondly, mention whether umbilicus is circular or is it transversely stretched. So instead of the umbilicus being circular, it might be somewhat like a smiling umbilicus. This is again seen in cases of gross ascites. Next, comment whether the umbilicus is inverted, whether it is everted, or whether it is flushed with the surface. What is meant by flushed with the surface? So this is an inverted umbilicus, everted umbilicus, and umbilicus which is flushed with the surface. Again, in gross ascites, you will expect everted umbilicus. Next, comment upon the general appearance of the abdomen. So mention whether the abdomen is flat, whether it is scaphoid, or whether it is distended. Scaphoid is basically meaning boat shape, where you will have a dip in the abdomen. And distended is what you will expect in case of ascites. Next, comment upon the flanks, whether they are full or free. You will expect flank fullness to be present in a case of ascites. Next, mention whether there are any scars, sinuses, or dilated veins. In cases of ascites, the skin over the abdomen may be stretched and shiny, but more so only in tense ascites. Next, we mention about hernial orifices, whether they appear normal or not, and comment about external genitalia. So nephrotic can have scrotal or vulval edema. Then comes palpation. Before performing palpation, one point that we often miss during our exams is that we do not ask the patient to flex his hips and knees. And the examiner will catch you on this point. Please do not forget to tell this to your patient. First part will be superficial palpation. You mentioned that there is no local rise of temperature and tenderness. What if tenderness is present? In which condition will tenderness be present in a case of nephrotic? You can write in the chat box. Yeah. Yes, sorry, it is peritonitis. Next, we will perform deep palpation to look for organomegaly. You will be checking if there is enlarged liver or spleen or kidney. So there are various methods to check for hepatomegaly, splenomegaly, which we will not be discussing right now. I will be maybe taking a offline session only for the examination part, where maybe I can demonstrate you guys how to do palpation for hepatomegaly and splenomegaly. As for kidney, we will perform a bimanual palpation. So how is a bimanual palpation done? I will stand on the right side of patient. I will place my left hand below and right hand above, and I will try to approximate my hands, and I will try to feel for both the surfaces of the kidney. If I'm able to palpate the anterior as well as posterior surface, it means that the kidney is significantly enlarged, and I will be able to gauge to what depth or the size of the lump by performing bimanual palpation. Okay, that is about deep palpation. Next, we will be performing fluid thrill. So, fluid thrill should be attempted only if there is a tense ascites. If tense ascites is not present, directly go for shifting dullness and horseshoe shaped dullness. How do we do fluid thrill? Uh, I think you guys have read about this. Pratham, can you unmute and tell me how do we perform fluid thrill? Pratham Yadav.
Yes, sir.
Yeah,
So,
go on.
so first we put the patient border of the hand on the stomach, on the abdomen, and then we place our other hand on the opposite side of the abdomen, and with our right hand we flip on the side of the abdomen and feel for the sensation for the thrill on the opposite hand.
Yes, that is absolutely correct. We'll ask the patient to place his ulnar border in the midline. We'll place one hand on the right side to palpate for the impulse, and with the other hand, we will give a flick with our fingertips, and we will palpate if there is any impulse on our right hand. If fluid thrill is present, it means there is gross ascites, and it means that the abdomen is filled with fluid right up to the top. Next, we will check if there is any tenderness at the renal angle. So, what is this renal angle? Renal angle is formed by the 12th rib on the back side and the erector spinae muscle. Let's say these are the ribs, the vertebra T12, L1, L2. So this space between the 12th rib and the erector spinae muscle is the renal angle. When the kidney enlarges, it first enlarges in this space. There will be fullness of the renal angle, which indicates that there is renal enlargement. If tenderness is present, it could be indicative of pyelonephritis. All right. Again, just like we mentioned, hernial orifices and external genitalia in inspection, we will again comment upon them in examination. They are normal on palpation. Anyone having any doubts so far before I move on to percussion? Please type in the chat box. No doubts? All right. Okay, so percussion. First of all, you will do percussion on any enlarged organs if present. Usually, if you focus on an enlarged liver or enlarged spleen, most of the times you can expect a dull note to be heard. Secondly, we will check for free fluid. There are two methods for it. One is shifting dullness, and second is horseshoe shaped dullness. I'll be explaining the procedure in a minute. Third point is liver span. How do you calculate the liver span? So start percussing on the right side in the second intercostal space. You will be getting a resonant note. Percuss each intercostal space until you will get a dull note. This marks the upper border of your liver. Continue percussing until the dull note disappears. By measuring this distance, you will be getting your liver span. These three are the points that you will be commenting upon when you mention your percussion findings. Okay, now I'll be explaining shifting dullness. It is a bit different than what you have learned in your physiology lectures. So first of all, we will start by percussing. Let's say this is the xiphisternum and this is the pubic symphysis. I will start percussing from the xiphisternum down to the pubic symphysis. And let's say I'm getting a tympanic note throughout. So what does that mean? It means that either there is very less free fluid in the abdomen, or free fluid is present only in the flanks, or it could mean that there is no free fluid. Okay, because if there is very less free fluid, it would first appear in the flanks rather than in the midline. Next, I will go from the umbilicus towards the right side. I will percuss from the umbilicus towards the right side until I hear a dull note. I will mark this point. Then I will ask my patient to turn towards the left lateral position. Wait for a minute for the fluid to flow through. Then again percuss at the same side. You will get a tympanic note. Start percussing towards the left until you again get a dull note. Initially, the dull note was present over here, and now the dull note has shifted to another position. This is what you call as shifting dullness. So far, are we clear about this? Then I will move on to horseshoe shaped dullness. Devans, is it clear? Or do you have any doubt with respect to shifting dullness? Okay. So suppose when I'm percussing in the midline from the xiphisternum to the pubic symphysis, this being the umbilicus, and then I'm getting a dull note in the midline itself. Okay, only if you are getting a dull note in the midline will you perform a horseshoe shaped dullness. Otherwise, you don't have to perform horseshoe shaped dullness. In this case, what I will do is I will go back to the umbilicus and start percussing radially until I get a dull note. And by joining all the points of dull note, I will get a horseshoe shape. By this method, you have elicited horseshoe shaped dullness. But wait, there's one more point. What if when I'm percussing in the midline, I get the dullness above the umbilicus? In this case, you don't have to go radially from the umbilicus. You will be going radially right from the xiphisternum. And you will be getting dull note again in shape of a horseshoe. Is that clear? Do you have any doubts with respect to this? Prachi, is this understandable?
Yes, sir.
Okay. So in percussion, we have mentioned about the tone over the note that we hear over enlarged organs. We have mentioned whether there is free fluid or not. You can expect free fluid. You can expect fluid still to be present in a case of nephrotic syndrome. In fact, only if there is ascites will the examiners consider to keep that case in your exam. Otherwise, there aren't any other significant findings. Last comes auscultation. It will have 2 points. One, peristaltic sounds are heard. Also mention how many, like 3 per minute, and say that no other abnormal sounds are heard. What are the abnormal sounds that I'm expecting to hear? It may be bruit of an artery. For example, there may be renal artery stenosis, in the case of which we will be hearing a bruit, or there can be a venous hum. More so relevant in a case of portal hypertension, there won't be any abnormal sound for nephrotic case. Last, how do you present the diagnosis? So, Shaurya, can you unmute and tell me what were the components of diagnosis that we discussed yesterday?
Sorry, sir, I can't recall.
Okay, so diagnosis had 3 parts: the name, etiology, and complications. For this case, what I will say is this is a case of first episode, or if there is past illness, then recurrent episode of idiopathic nephrotic syndrome, most probably minimal change disease without any complications. One more point I had to add over here. Sorry, I'm sure you must be remembering what findings do we mention in other systems. Sorry,
No,
can you please unmute? Yeah.
no, sir, I can't say.
Okay, no issues. After we complete the abdominal examination, we'll mention CVS S1 S2 heard, no murmurs, RS bilateral equal air entry and no adventitious sounds. And for CNS, cry, tone, appearance are normal. I have covered this part in the previous session, so you can take notes from there. One thing I want to mention is that in respiratory system examination, do seek for pleural effusion, which is a known complication of nephrotic syndrome. Otherwise, other systems would be mostly normal. So that is about your case for nephrotic syndrome. Some of the expected Viva questions that you will be asked will be, first question being, what is the management of nephrotic syndrome? So management is not just treatment, it is composed of investigations as well as treatment. What all investigations will you order? Whoever knows the answers, please type in the chat box. What investigations will you do for a case of nephrotic syndrome? Kshitija, if you are in the library, you can type it or else unmute and answer. Yes, Sanskriti. Serum albumin. What else? See, recall the points that we just talked. Yeah, urine analysis. We'll check for urine proteins. We'll do 24-hour urine protein. We'll also be doing urine culture. Why would we do urine culture in this case? Is it an infective cause? See, there could be a urinary tract infection which has precipitated a relapse. Relapse of nephrotic syndrome. That is why we will do urine culture. What else? Antibody titer. Okay, if you want to rule out PSG and you will do antibody titer. Biopsy is not necessary in cases of idiopathic nephrotic syndrome. Usually, what we do is we start with steroids, and if the patient responds to steroids, we assume that it is a case of MCD. If he's still not responding, and suppose the C3 titers are very high, then yes, we'll suspect that it is some alternative diagnosis, and then we'll do renal biopsy. Otherwise, we'll also do some simple tests such as blood urea and creatinine, which will give us an idea whether there is renal failure or not. We will be checking serum cholesterol levels. As I mentioned, there is hyperlipidemia. And we will also be doing X-ray and Mantoux test. Why X-ray? What if the child had TB and you gave him steroids, which are immunosuppressants? So it is necessary to rule out TB before starting steroids. That is an additional point. Next comes treatment. Sanskriti, can you unmute and tell me what is the treatment for idiopathic nephrotic syndrome?
We give steroids, uh,
Yeah. Which steroid?
prednisolone.
Yes. Do you remember the dose?
Like those, I don't remember, but like there are two classifications. Like if it is dependent, like steroid dependent, and then steroid resistance. So for steroid dependent cases, we give cyclophosphamide, and for steroid resistance, like we give cyclosporin and tacrolimus.
That's excellent. You need to remember the doses. Nephrotic syndrome is a very important LAQ for your university exams. So the dose is 2 milligram per kg per day, which we will give for 6 weeks daily, up to a maximum dose of 60 milligram, followed by 1.5 milligram per kg per day, again for 6 weeks, given on alternate days, max dose of 40 milligram. See, when you will start with your fourth year preparation, when you open Bulur, when you open Ghai, there will be a long list of all these regimens. Every disease will have its own treatment, its own regimen. It might be confusing at the first go, but I don't think each and every dose is necessary. There are certain important questions, one of them being nephrotic, where you must know the dose. So this was for the initial episode. What if the patient has a relapse, but it is infrequent relapse? Well, then you will treat each and every episode with the same regimen as we discussed above. But what if he has frequent relapses or he has steroid dependence? Now you cannot give steroids for a long period of time, as you must all know that steroids over a long period of time will lead to many adverse effects. So instead of steroids, we will be using immunomodulatory drugs such as levamisole and mycophenolate mofetil, like Sanskriti correctly said. Third case, What if it is steroid resistant nephrotic syndrome? When I say steroid resistant nephrotic syndrome, it means that the child is not responding to steroids. In this case, we will be using calcineurin inhibitors. Examples being cyclosporin and tacrolimus. All right, that is the treatment regimen for nephrotic syndrome. Also, you may use diuretics in case the child has massive ascites and edema over the body. Next, Tanushree Arya, can you unmute and tell me some of the complications seen in nephrotic syndrome? We have already covered 2, 3 before. What other complications can you expect in nephrotic? Okay, you don't know, no issues. So infections is one of the complication. Second, someone had told earlier in the chat box that thrombosis can occur due to hypercoagulability. This occurs mainly because antithrombin 3 is also a protein which will be lost in urine, and this can lead to manifestations such as stroke, respiratory distress, as we discussed, due to pulmonary edema or pleural effusion, and you can expect growth retardation. This will be both due to protein loss as well as due to long-term steroid intake. Last, you can be expect certain you can expect the examiner to ask you certain definitions. So, Chris, can you unmute and tell me what is remission in a case of nephrotic syndrome?
So for 3 consecutive days, the when spot albumin is nil.
Right. So urine albumin will be nil, or it would be in trace amounts for 3 consecutive early morning specimens. Chris, what is the cutoff value for the protein urea or protein creatinine ratio when I want to label it as nil or trace?
Don't remember, sir.
So protein urea less than 4 milligram per meter square per hour, and protein creatinine ratio less than 0.2. If you can recall, at the beginning of the session, to define nephrotic syndrome, I told you that protein urea has to be greater than 40 milligram per meter square per hour, and PC ratio was greater than 2. Here it is 4 and 0.2. So remission is basically the patient had a disease and now he doesn't have a disease. Whereas relapse means that the patient had been in remission and now he again has the disease. So it can be defined as, again, he has nephrotic range protein urea, the same values that we discussed at the start of the session for 3 morning specimens, consecutive morning specimens, in a patient who has been in remission previously. Next, I mentioned a term, frequent relapses over here. So how frequent do we call a frequent relapse? Um, Sanskriti, can you unmute and tell me how frequent is it? Does it have to be? Is there a certain value or do we just say it arbitrarily?
Uh, uh, there are certain values, it should be more than I guess it should be more than twice in a week and 4 times in a month.
Okay, it's not in a week because our regimen was of like 6 weeks. So you can't expect the remission to happen in a week. It is greater than 2 relapses within a period of 6 months and more than 3 relapses within a period of 1 year. Is that all right? Next comes, how do you define steroid resistant nephrotic syndrome? As I explained, steroid resistant means this child is not responding to steroids. Does remission mean patient no more has disease? How should we interpret? Remission means that the patient now has nil or trace albumin. He does not show the symptoms of nephrotic syndrome. But nephrotic syndrome is a disease where uh, symptoms may exacerbate again. It is likely to recur. Although over time, the patient shows complete remission. But just a single remission, you can't predict exactly whether the child will show relapse or not. Maybe this has been the first episode and now the patient does not show any episode, does not show any symptoms. That means the child is in remission. But it's not about symptoms, rather about these values that we use to tell whether he is in remission or not. All right. Steroid resistant nephrotic syndrome can be defined as absence of remission despite giving him therapy with 2 milligram per kg per day for 6 weeks. So at the end of 6 weeks, if the child does not show any remission, then we label this child as steroid resistant nephrotic syndrome. Next comes steroid dependent nephrotic syndrome. What this term means is that the child does show remission after we give him steroids, but as soon as we take away the steroids, he will again show a relapse. To define it, you can say the criteria is that if there are greater than 2 times there is a relapse when the child is on alternate day steroids, or there is a relapse within 14 days of stopping treatment. Then you label it as steroid dependent nephrotic syndrome. I will explain it once again. Suppose we have completed with the 2 mkd daily dose of 6 weeks. Now he is on 1.5 mkd. He shows a relapse. He shows a relapse once. Again, we give him the regimen. He shows a relapse twice. Or else, after completing the 1.5 mkd regimen, he again shows a relapse. In these cases, we will label him as steroid dependent nephrotic syndrome. These are some of the definitions that you may be asked during your Viva. That's it about nephrotic syndrome from my side. It's a pretty easy case for your examination. And it's a very scoring case also. There's not much that you need to remember, just a few facts and figures here and there.